All right, I think we're live. Ladies, thank you for joining me. My name is April, and I, as most of you know, is the nurse educator. We're all come together to talk about this NEVER event that happened. But first, I want you all to introduce yourselves. Danita?
Hi, I'm Danita, and I'm a new graduate nurse.
Diane?
And my name is Diane, and I am the nurse manager for the unit.
And hello, my name is Sharon, and I'm a nurse informaticist at the hospital.
Thank you all for being here to help try to figure out how to prevent this NEVER event from occurring. I'm going to give a brief overview, and then we'll get into the dirt. We had a 33-year-old female patient come into our ER complaining of nausea and vomiting for 3 days. She was diagnosed with breast cancer, was getting outpatient chemotherapy, and she had a port which was accessed when she came into the ER. She was given a 1-liter bolus and some Phenergan in the ER. She also had a CBC, a CMP, a nasal swab done in the lab as well, done and sent to the lab as well. From there, she was transferred up to the unit where, as I believe Danita took the patient for a new admission on the unit. From there, I'll let you guys fill in the blanks, but the basic overview was that the lab came back as a critical potassium at 2.2. The nurse was informed of that. She informed the doctor. The doctor put in an order for 60 milliequivalents IV potassium chloride stat. And Danita gave that entire 60 milliequivalents and caused our patient to go into cardiac arrest. Thankfully, the patient made it through. She's up in our ICU now. But we want to walk through these steps because as an educator, I need to make sure that I'm doing my part in making sure you all are educated. Now, as the manager, do you want to give me your point of view, Diane?
Thank you, April. Yes, I do. First of all, I want to quote, we're all here today for a very scary event that happened. And, Danita, we're not putting blame because we've all been there. As a novice nurse, we've all seen mistakes happen, and all we want to do is rectify it. Martin Luther King said, "The function of education is to teach one to think intensely and to think critically," and that's why we're here today, because we have to think intensely and critically so this NEVER event never happens again. There's 3 things as the manager that I worry about and are more frustrating than anything. First of all, the costs. Now, don't get me wrong, we're all, of course, concerned about our patient. We're glad she's stable in the ICU and came out of this, or is going the right direction at this time. But the costs, and in the NEVER event, according to the Center for the Medicare Advocacy, thank God this event is covered, but there are certain events that are not. And even though this is covered, it's still going to cost. And I spoke with the family, and of course they're very upset. They're worried about the costs they're going to accrue, and I had to ensure them that they are not responsible for them. They don't have great insurance. They're worried about their loved one. The finances, the concern of the everything. So it was very, very a dramatic event for everybody involved. The next one, our process. Now, obviously, our process failed us here. Something happened that this woman got the potassium too quick. And obviously, the outcome of care was cardiac arrest. Those are the 3 frustrations, and that's why we're here. It's obvious we have to do something or restructure our healthcare delivery and maybe adapt a culture of safety. Danita, just asking you a question at this time. At the time of the event, can you tell me what you were feeling? Did you feel overwhelmed? Did you feel? Tell me what you're feeling, because that's why you're on this committee, because we need your point of view. We need your input.
Well, thanks, Diane, for asking. I I was really overwhelmed that night because it seems like, every time I get on the shift that, since I'm the new grad nurse, they want me to, have the higher acuity patients. So I just feel like every time I get on that I keep getting dumped on, and the charge nurse, she's never really available when I need her. And I have all of these high acuity patients that I feel like I can't take care of on my own. And, I felt really bad because that night I wanted to ask for help, and I went to the charge nurse to ask her if she could help me because I wasn't sure. I've never really hung potassium before. And when I asked her to help me interpret these orders, she just kind of pushed me away. It was like, I'm too busy right now. I have patients. You just, figure it out on your own. So I was really scared. I already had a lot of problems going on with my other patients. I was extremely busy that night. And when I got the orders from the doctor saying that, this is a critically low value and he needs to order 60 MEQ stat and give them immediately, well, immediately to me was like right now. So I thought, since it was such a critical value, that the best thing I could do at that time was just to give her the entire dose. And that's what I truly thought. I was never out to hurt my patient. I never want to hurt my patients. And that's just how I interpreted everything at the time, was just give it to her now and hopefully it'll help her get better soon. So that's kind of what happened.
Okay, so Danita, that night the charge nurse had her own patients. You felt very overwhelmed. Your acuity of your other patients were very high.
Yes.
Okay. And how long were you on your preceptor shift? How long?
When I got hired, they told me since I was a new grad that I was going to have a 3-month training with a preceptor. And I guess what happened was after 2 months, there was a lot of people, a lot of nurses that quit and left, and the unit was really short-staffed. So it was really hard for me to get proper training. So they took me off of orientation super early after 2 months and said that I'd be fine on my own, which I felt like I really wasn't. But I didn't want to make a stink about it, and I just wanted to, be the best nurse that I could be. So they took me off of orientation after 2 months, and now I've got all these patients, and I'm not even sure what to do with.
And April, what's the normal preceptorship? Like, how long are these novice nurses supposed to be with someone?
The novice nurses are supposed to go through a 3-month orientation. We have specific checkoffs for everything in the binder here. And as far as the binder and all of her checkoffs, she signed them all. I mean, according to this, she's done with orientation as far as the book work goes, and the things that she didn't actually get to do, she stated that she was taught it by either myself or one of the other nurses on the staff. So there isn't actually an electrolyte-specific IV infusion checkoff. So, but she did sign this agreement that if ever she had problems, she would make sure she asked someone else before proceeding.
Okay, so this is where I feel like I kind of have to own this since I'm the manager of this unit, because she did ask, and my charge nurse was not available to her, and this is what happened. Obviously we have to work on fostering a cohesive group, and it's for nurse retention, so maybe we're not short. So, Danita, again, I kind of own this too. Maybe a signature, just because she signed it doesn't mean she knows it. We've got to implement something else, because this can't never happen again. Sharon, can you give us a little information on the pharmacy part of this, how she ended up with 60 MEQs?
Yes, I can. And actually, I want to say, Danita, I'm sorry this is happening, but you're not the only person that this has happened to. According to an article by Anderson and Townsend, that the #1 cause of inpatient fatalities is medication errors. And there's at least one medication error that occurs per hospital, per patient, every day. And so from an informatics perspective, I'm going to lay the groundwork for what happened during your shift, Danita, which is very unfortunate. But then also we're going to work with the pharmacy to come up with a plan to help us so that this doesn't happen again. Because we have recognized from this event, Danita, that there are some holes in our system that need to be fixed. So first of all, I'm seeing from all of the electronic records that we use, and this would be our electronic health record, our physician order entry system, our lab system, and our bedside scanning system, we can see the time chain for how things happened for you that night. So I'm seeing that at 8 p.m. you received a critical potassium level of 2.2 from the lab. That was noted in your charting because you notified the physician at 8:10, and that was in a timely manner considering all that you had going on. The physician did place an order into the computer entry system at 8:20 p.m. for 60 milliequivalents of potassium stat. You didn't get to pull the potassium from the Pyxis system until 10:05 p.m. But when you got it out of Pyxis, it was for the entire dose of 60 milliequivalents. That would have been 3 bags of 20 milliequivalents. And then at 11 p.m., the entire dose was scanned into the EMR, into the electronic system, and you scanned the patient's bracelet at the same time. And then noting that you were administering the dose. And then at 11:20 p.m., the patient had a cardiac arrest.
Yeah,
Now,
that's kind of how it went down.
So I can see in your charting that it's exactly as you said with your shift, with all the things that were happening during your shift, that you were overwhelmed. From an informatics perspective, our job is to make the bedside nurse's job easier and using all of our electronic devices to help care for the patient. Now, according to another article in the British Journal of Clinical Pharmacy, there are things that each facility can have in place to decrease med errors, and we're doing some of that. We're doing a lot of those. We have computerized physician order entry system, we have the Pyxis system, and we have the bedside barcoded administration system. But we don't have a clinical support decision for nurses in the medication administration record, and that could have been helpful for you that night, Danita. But the physicians, they do have that in their order entry system. So they can see when they're ordering too much for a patient over too short of a time period, they get a warning. And the same thing should have been in place for you at that time when you were scanning the 60 milliequivalents. So I am working with the pharmacy with that to see if we can get that input into our nursing documentation. And also they have some other recommendations as far as, from their standpoint, what they can do for us to prevent this from happening in the future.
Now, I had a question. As your educator, we took you through a course on the EMR, right?
Yeah.
On the EMR, did you notice that they were scheduled 2 hours apart?
No, I didn't, because I think how I interpreted the order was, you know, if it was like a scheduled dose, then I think I would have, you know, possibly followed the order. Let's say it was like 10 cc's per minute or whatever. You know, I thought stat meant right now, so all of that went out the window. So I guess my personal interpretation of stat was like, you know, whatever the doctor ordered, give it right now. So that's what I thought. And, you know, I did have a question about that because I couldn't find a 60 MEQ bag, and, you know, I had to get 3 20 MEQ bags, and that's why I had a question for the charge nurse to say, like, I don't know, these orders just aren't adding up. It didn't make any sense to me. And, you know, like I said, she wasn't around to help me, so I just kind of went with it and thought, this is an emergent situation, so I possibly need to give it right now.
I understand that, and I think this is one of the reasons we need to especially take care of our new nurses when it comes to education, because there's an article here about how experience and medication errors, specifically IV and serious ones, they're correlated. You know, the more experience, the less errors there are. In fact, on this by Westbrook, Rob Woods, and Perry, from the IBJ, it said that almost 70% of the 568 IV medications that they gave had an error. 25 were serious ones, and like I said, the more experience they had, the less frequent they had errors. So with you, Diane, I mean, Diane as the manager, me as the educator, you know, I feel like I made sure all my I's were dotted and T's were crossed to make sure she's there, but we took her off too early, and we need to make sure it doesn't happen again.
I agree, April. I definitely agree. I think, like I said before, I feel like I kind of have to own this too, being the manager, Danita, that I'm not fostering the cohesive team that I need, and we've got to change that. How we're going to change that, that's one of our questions. How are we going to get that? How am I going to get that team where I can keep my nurses, keep the retention, keep the, when you ask, especially a novice nurse, and even a seasoned nurse, we all have questions. So, even if a seasoned nurse had to go to that charge nurse, it doesn't matter. We're all there for each other. We're all there for support. We're going to have good days, we're going to have bad days, and unfortunately, some days are going to be short, but we definitely don't want this to ever happen again, and that's our main goal here. So again, Danita, I'm really sorry. I appreciate everybody coming to the meeting, but let's come up with more questions.
So that was your question on how to create a culture of safety on our unit?
Yes.
And mine is from the pharmacy standpoint. I want to work with the pharmacy and our informatics system to determine how we can come up with other avenues so that nurses can be supported in so that nurses can have a clinical support system built into the medication record, or maybe even a way to obtain information regarding medication. So how can the pharmacy help us come up with other avenues to prevent medication errors?
Right.
Very good.
Sharon, you have a lot of great ideas already, but a very good question.
Right. At this point, we're just trying to get all the information together for the quality improvement team to analyze and figure out for us and give us feedback on where to go. But again, your two questions as well as my question is how do we get an education system, an orientation system set up that will make sure that our nurses, especially the new ones, are prepared and ready to go out on the unit and take care of the patients.
Right.
Safely.
Yeah, absolutely.
Did anyone else have anything to add?
Not at this time. When are we going to get this report ready? April, are you going to hand that over to the QI team for us?
Yes.
Okay. And when will you have that done by?
That will be sent to them today, and hopefully we'll get feedback by the end of the weekend.
Perfect, perfect. And we'll meet again.
All right. Thank you, ladies.
Good night, everyone. Good night.
Good night.